interesting session, and in my opinion, it is same quality as the ASH. And Dr. Barnett, don't worry about your first presentation. I don't like to hear about history of AML. You enlightened us with the future, with the new drugs. Beautiful. And so the just I have to correct one information from Dr. Marwan about the transplant program in Jeddah started 2001, not 11. So the question to the panel now, how you think we should treat patients with AML, adding one more point. I think Faisal Specialist Hospital in Riyadh, they have next generation sequencing in place, and it is currently under validation, and they do accept cases for myeloid analysis and bone marrow failure analysis. This is a message, I got it from Dr. Salim Khalil yesterday. He sent me this. So it is, or on Thursday. So I think it will be there. So if we have this tool available, how do you think we should treat our patients with AML, including the pediatrics?
How we, sorry, lost you.
Myeloid panel. How would we treat patients with AML if we now have
after this excellent session, we need to take home messages. There are lots of attendants, and everyone, when he or she will go to her or his institution, they will try to do this and how you treat. So Dr. Ali will say, for adolescent and young adult, you will recommend to use pediatric. In AML, Dr. Barnett and Dr. Said Osman, and transplantation.
Right. I guess if you are specifically asking about the AYA group, it's, as I mentioned, it's very hard to conclude one paradigm of treatment for them. And I think certainly it needs to be discussed, what the pros and cons of each protocol, and coming up with one, because still up in the literature, it's not really that clear what to use, and each arm had pluses and minuses. EML is certainly not one disease, and either a low risk or a standard or a high risk. So we are currently using just one hammer to treat all of them, and then risk stratify by using either chemotherapy or transplant. It's been showing clearly that for the low risk, at least in the pediatric age group, that BMT is not really adding any survival advantage, however, in the intermediate and the high risk it does. But again, for the AYA, certainly future trial needed to be done.
But why the AYA, they are deficient in the new drugs that Dr. Burnett talked about? Why they are shying away from utilizing these new, I would say, magic drugs that may change?
Enrollment is a big challenge, as I show in there. And AML is certainly a disease of elderly and adulthood, and which unfortunately did not capture those.
Okay, thanks. So this is on record, right? This is being beamed on YouTube, so I have to be careful what I say and how I say it. So essentially what I want is the test result. There are certain things I need now, and there are certain things I can wait for. So a FLT3 result I need now, and alhamdulillah, in the lab we're able to get it in 48 hours. I still need the cytogenetics. The NGS does not replace the cytogenetics. We'll, inshallah, hope to be able to get a FISH result within 24 to 48 hours. That'll help us with modified. So, at the moment, if we talk about King Faisal, we get a good panel based on sequencing, not an NGS panel, and we get it within 2 weeks. We have most of it. We get a FLT3 within 2 days. We get a IDH1, IDH2, NPM1, we get a WT1, we get an NGA, we get a DNMT3A, we get a KIT. So, and we get the CDC alpha. So we get that quite soon. So the only thing additional that we need is an allelic ratio, a TKD. And I need the TKD, FLT3 TKD, I need it as soon as possible because I can use myrostatin for it. I can't wait 4 weeks for the panel result to come back. So, and then the other ones are the ASXL1, RONX1, TP53. If you go by the ELN. That's what you need. So at the moment, I would say, if the lab can give me just PCR-based results for these 3 additional ones, which doesn't have to be now, I'd be happy. I know NGS is fancy and we've been pushing for it, but to be completely honest, the problem is it takes time, and for some things, especially the quantitative results, you still need the wet lab work in your place to do it. The core binding factor quantitative PCRs, the NPM1 quantitative PCR. And even the ITD, you will still need your lab to do it. Your NGS panel won't give you a full ITD result. So, it really depends on what you want. If I got the sequencing results, and you can take as long as you want to get your NGS myeloid validation done, if you can do me a PCR.
I don't know how I can follow that exactly. We always had a 10-day induction schedule, and so you've got plenty of time to get your FLT3 information back, because you're not going to give the inhibitor combined with chemo. You're going to give it sequentially. I guess with the current state of play, I think the thing probably I would want most would be to know the CDF situation. And the morphologist is not entirely useless there. He could at least say, I think we should have a FISH done on this, so you'll get your answer in 24 hours. I think the evidence suggests that you can usually safely not treat a patient for 48 hours or something like that. So that's all feasible. I think in the future you have to identify in that first month who you can follow for MRD and by what technique, because I think they are going to, as I'll show later, are going to determine your choice of transplant very clearly. And then if these drugs are validated, and new drugs are validated, you'll need to know the IDH1, IDH2, and you'll probably add these drugs to your standard for chemotherapy, I think. So I don't know the logistical issues in relation to NGS for MRDness or etc. But at the moment, you would want your lab, if you didn't have that, you would want your lab to be able to do the FLT3, the NPM1, the allelic ratio, the NPM1, the M2. Although we do it, we don't need the CDP alpha, because we regard that as, unless it's, if it's biallelic, then it doesn't need transplant consideration. So that's about it, really. I think we can get away without NGS for a while yet, if you have an experienced flow cytometry guy to look at your MRD.
If you allow me, just I will add also, in a non-transplant center, please consider referring the patient earlier for transplant workup. Not need to change, just we need the HLA type and preparing the patient mentally that transplant can help, and as you saw, that early transplant will help.
Right. Excellent discussion from the panel. Two questions. First question to Professor Alan Bernard. Why Myeloid is specifically working in the favor of growth? And, because I don't think that the mechanism only targeting CD33, because, it's being present in some, like, other, in the high-risk group. So if there is any other mechanism that we are looking to Myeloid working to improve the response in those patients with, specifically with the favor of growth. Second question for Dr. Said Othman. The use of MRD in AML, I think it is still, um, we are still early than it would be expected because, ALL is confronting, we know that ALL has been now standard of care to use MRD. However, in AML, we see some AML disease that relapse with different clones. And some of these also targeted mutations, it may persist like RNX1 T1, persist for longer time, and there is no risk of relapse. And this is thing that we should wait. We should not look at the MRD for decision making. So.
So I'll try to answer the question on CBF and why it does better with Myeloid. The question. The CBS probably, if you believe it, the CBS probably have a better expression of CD33. They also have a lower expression of P-glycoprotein, and the Myeloid, the gemtuzumab, is subject to P-glycoprotein exclusion from the cell, at least in vitro testing. So that might make a bit of a combined argument why CBFs are more susceptible. Against that argument is that the story across all the GO experience in relation to CD33 expression and correlations has been very patchy. Some studies say yes, some studies say no. And I think it's down to how the CD33 is measured and recorded. We looked at PGP in, I think, the AML15 study as to whether that was a variable, and we didn't find a clear relationship. The numbers may not have been good enough. There may be other resistance proteins that are in play that we didn't look at as well.
Just a point about the MRD in AML not being quite where ALL is. Usually the pediatricians are leading the way, and maybe we're catching up. But I think you're right, and I think that was the challenge with AML. I mean, some years ago, I think it was Elizabeth Payetta who put up a slide and ASH said MRD ALL is not equal to AML because of the challenges, some of which I mentioned. But I think, it is they're getting better with 10, 12 color flow and being able to identify marks. Obviously now there is that ELN, MRD sort of recommendation. So I think we're heading there, but I think what is very useful is using different modalities together. So for example, when you have the core binding factor in 821, and you have the flow, and then you have the molecular, and you have the fish, right? And the pathologist may say, this flow is really suspicious. If you've got a fish that's negative, and the molecular shows you very deep remission, then maybe this would push you more towards it being maybe some regenerated blasts. So I think it's not where ALL is, certainly not in sensitivity, but I would think maybe using the modalities together will help you make a decision, and maybe with NGS being thrown in there as well as a further modality. You'll put more than one piece of information together.
The one leukemia we're not talking about today is APL, and there is a genuine need to know about that. My colleague Tony Goldstone used to say, never let the sun set on an APL. You have to act on the same day. And getting that information back is of crucial importance. But if in doubt, give them action. The PML antibody is useful, but it's a little bit, as I understand, a little bit of an experienced eye is required for the APL PML antibody, which is pretty specific for the transplant.
Prof. Burnett, I have two questions for you. First one is your comment about autologous transplant of intermediate risk AML. Marwan has talked about the phase early of experience. And the Second question about elderly patients with acute myeloid leukemia. Now we have plenty of options to go with. Used to be only low-dose RIC or Vidaza. Let's say someone who is elderly and has a plethora acute myeloid leukemia and he cannot tolerate intensive chemos. What kind of regimen you would use for this patient? Kind of upfront.
Dealing with the older patients, I don't mind whether it's azacitidine, decitabine, which is a little more inconvenient, or low-dose Ara-C. They're all about the same. I think the big issue, though, I think if the venetoclax addition isn't established, that is a game changer. Undoubtedly, I think that's the best thing. And people are even now talking about giving, and remember, it's not particularly influenced by risk. So you get the same sort of response in the adverse risk group as you do in the normal risk group. That's important, and people are now talking about giving that combination instead of E plus 7 to older patients. And I think that's going to pan out. That could be quite interesting. So I think venetoclax is a very interesting drug to go forward with. And if I had AML at my age, that's what I would want. Thank you, doctor. What was the first question?
Your comment about auto and intermediate risk AML, autologous transplant.
I'll talk a little about how we define risk for transplant or not. We've moved through cytogenetics to additional risk scoring, to using the MRD positivity in NPM1 after course 2, that becomes high risk. Taking patients out of the intermediate with MRD negativity, I'll talk a little bit about that. So we moved from having transplant in the intermediate risk in AML 15 to taking it out of AML 17 by redefining risk and increase the size of the high risk, but it took more than half the intermediate risk patients out from transplant. So that's been a challenge for a while, and no doubt it will continue to be a challenge. I mean, I just like annoying transplanters, you know. I think autograft, however, it's a long time since we've seen a randomized study. I'd like to see another randomized study in autograft. I think it is being used again, but it's not in the randomized context.
Just one thing that's happening in the UK, I wish we can have the same thing in Saudi Arabia, is the centralization of diagnosis of leukemia. It needs lots of resources, labs, equipment, and what I understand from you before, that in UK you have these patients, all they will go to provinces, but then a central lab, and there might be delay, and these patients will be given hydroxyurea till the final diagnosis arrives, and then analysis was done, and it was shown that using hydroxyurea for a few days or 1 week was in favor. Is this true or it's changed?
In the early days of the MRC trials, very influenced by the Hammersmith, there was central review of the morphology done by David Swirsky, the late David Swirsky, and he went to Leeds. And we looked at this and thought, this is getting in the way a little bit, and it's a big burden. As the trials grew, to 600 a year or 1,200 as it is now a year, it's too big a burden for one guy. And we looked at the data as best we could, and the local hematologists were seldom wrong. So we don't require central morphological review. We rely on local cytogenetic labs who are in the National Quality Assurance Scheme, and we have 1 or 2 molecular labs, and we have 1 or 2 MRD labs. And that's for about 150 hospitals in the UK. So it's fairly well organized. It runs in parallel with a cancer initiative for healthcare, where doctors have to work in collaborative groups to assess patients, treatment plans, etc. So you get no lone rangers anymore. That's not allowed.
Thank you for the elegant presentations. Actually, my question goes to Bernard. Probably you answered part of the question about the role of auto in core binding mutation patients. And you said you need to see more randomization before you reach such conclusion. How about MRD negative patients? Would you take them for auto transplant or not?
MRD. John Yin, as was pointed out, John Yin did a study showing that the log reduction was important. And if you had less than one log, you would relapse very quickly. In fact, you relapse so quickly, there was nothing you could do about it anyway, because they relapsed within a month. So we've never done any MRDness in the CBS now. Although these patients relapse, they have a very high second remission rate. So I wouldn't like you to conclude that that survival curve, which actually is about 85 to 90% now, is due to nothing happening to them. They relapse, but they can be rescued. And indeed, the evidence to say that you need to transplant them in second CR is not that strong, but we do. The other thing is that if you use FLAG-IDA plus hydroxyl consolidation, you get a very good CBS result if they get the treatment. And if you put FLAG-IDA plus GO plus consolidation hydroxyl, you actually can't see the difference. I mean, so the FLAG-IDA hydroxyl is a very good schedule, but it is myelotoxic, as I'll maybe show later.
So one last question. Prof. Burnett, back to the donor dose. The MRC trials, you use the second induction cycle. So if one is to use one induction cycle, can you fairly say that donor 60 is equal to 90?
It was about 90 milligrams single cycle, right? Yeah, you know, when I talk about 90 versus 60, we do give this second course of treatment, 5 plus 2, which is another 50. So ours get 400 milligrams or thereabouts of donidalorsen total, whereas the CLGB was 270. Unless they failed, and then they would get more. So that's the complication of interpreting that data. But we did not, when we looked at our overall survival curve against their survival, just blanked it on top of their curve, we saw no reason to change to the 90. Their control arm was not great, and maybe that's why the 90 looked a bit better. When we superimposed AML 15 saying, do we now have to change to 90? It was better than the 90 as it happened.
I think we will conclude the panel discussion now. In the interest of time. Are we having a break now? Okay, we'll go for a 5-minute break and we'll reconvene in about by about 11:10.